decorum as we can get. And so my name's Atur Singhi. I'm a professor at University of Pittsburgh Medical Center, and my colleague is Christopher Vandenbush, professor of pathology at Johns Hopkins Hospital. Today we'll be discussing some of the, I guess, in our opinion, the most challenging specimen types that we encounter on a daily basis, and that's pancreatobiliary FNAs and FNBs. Now, in the short time we have together, Chris and I debated how to go through the material in the course objectives, which obviously is a lot. And as we agreed, it would be best to present the course as really a case-based approach of 8 interesting cases that we actually encounter pretty frequently. And in so doing, we decided to focus on really providing a systematic or maybe an algorithmic approach to evaluating pancreatobiliary lesions by subdividing them into solid and cystic lesions. And then I think really as we go through the cases, you'll kind of get the gist of what we're trying to achieve, and then we'll have some time at the end just for some general questions. We're going to try to put the Q&A portion right at the end, but Chris and I will kind of divide up the talks overall. So let's begin with our first case, which is a 69-year-old male that presented with obstructive jaundice and on imaging was found to have a 3-centimeter pancreatic head mass. The mass was noted to be poorly defined, abutting the SMV, and associated with multiple enlarged peripancreatic lymph nodes. A ROSE was done by really 2 stains as we normally do, DIV-QUIC as well as PAPS. The left is the DIV-QUIC stain that showed atypical ductal epithelium, while corresponding PAP slides on the right consisted of really large stromal fragments. An FMB was also performed and yielded multiple fragments of blood and pancreatic tissue, and this tissue is characterized by fibrosis, mixed inflammatory infiltrate that consisted of predominantly lymphocytes, plasma cells, and eosinophils. And in other areas, there was a chronic inflammatory response, really emanating from the venous vasculature as opposed to the arterioles within the pancreatic parenchyma. Now, before going further, I typically take a step-back approach and evaluate pancreatic lesions, really kind of classifying it systematically or algorithmically, where I mentally go through the exercise of first broadly classifying the lesion based on imaging. In other words, is the lesion solid or cystic? And it's important really to kind of really identify the type of lesion you're dealing with as you go through a tree of a differential diagnosis. And really among solid lesions, pancreatic ductal adenocarcinoma by far is the most common. It comprises of over 90% of pancreatic cancers. But it's also important to remember that non-neoplastic entities, specifically chronic pancreatitis, can also present as a mass lesion in the pancreas and mimic a neoplasm. For obvious reasons, the distinction between chronic pancreatitis and adenocarcinoma is very important, but that distinction is not trivial, especially when dealing with ill-defined lesions like our case, and really paucicellular specimens like FNAs and now more likely FNBs. And therefore, to improve the ability to diagnose solid pancreatic lesions, new endoscopic approaches, really modalities have been developed, like through the needle laser capture or laser endoscopy itself. And in parallel, new needles have been developed that includes beveled, serrated, fork-shaped tips, and that have really been designed to really enhance the ability of pulling out tissue from the pancreatic parenchyma itself, such that our GI colleagues are getting really better and better at obtaining truly cellular material. Now, to digress for a minute, all of you are aware the interpretation of FNAs really relies significantly on architectural and nuclear abnormalities, which requires recognition of the normal pancreatic ducts, present as cohesive sheets of epithelium with round, uniform, evenly spaced nuclei, as on the left, really that classic honeycomb appearance on Pap stain. In contrast, adenocarcinoma on the right is characterized by nuclei that are crowded and show wide or uneven spacing. In other words, that drunken honeycomb look to it. But a different set of rules are followed when evaluating pancreatic FMBs or fine needle biopsies. For example, really you have to appreciate not only the architecture, but the growth pattern itself within the parenchyma. Many times it can show an ill-defined and interanastomosing glands, which contrasts that of reactive pancreatic ducts seen in the setting of chronic pancreatitis on the right. Typical differences between ducts seen in adenocarcinoma versus chronic pancreatitis are the ducts in the pancreatitis have clearly defined and wide open lumina with an absence of luminal debris. And at low magnification, there's a vague lobular appearance, as would be expected from the orderly arrangement of benign ducts within a pancreatic lobule. In contrast, pancreatic ductal adenocarcinoma has a haphazard growth appearance, and those glands often grow near muscular vessels, such as the arterioles in the red, and in proximity to nerves, which are labeled in yellow. Moreover, at higher magnification, adenocarcinoma often satisfies that so-called 4-to-1 nuclear rule that we often use in surgical pathology, which refers to 4-to-1 nuclear variation within a single gland that again contrasts that of reactive ducts when it comes to chronic pancreatitis. Finally, another helpful finding is the presence of glands touching or involving associated adipose tissue. Certainly as we age, our pancreas becomes fatty, especially in the tail of the pancreas and then later into the body. But the normal ducts should also undergo atrophy and eventually die off along with the acin or parenchyma. In contrast, adenocarcinoma is really resistant to programmed cell death and often invades the surrounding adipose tissue. Now, the histologic features that I've mentioned can really certainly help in establishing the diagnosis of adenocarcinoma, but only when applied to ducts or glands that are present within the actual tissue. The honest truth is that these FMBs, or really these next generation biopsies that many people call them, have lots of glandular epithelium that is free floating next to the tissue cores. This isn't surprising, as adenocarcinoma is often discohesive, often loses E-cadherin expression, in fact, and likely reflects loss of that cell adhesion mechanisms that allows them to really migrate, and that really being cell migration and tumor invasion. Therefore, not infrequently, there are many, you can get some fantastic tissue cores, but the adenocarcinoma itself is really not even present in any of them, but rather found at the periphery of these fibrotic cores themselves. Within there, and there importantly, recognizing features including a complex cribriform architecture, cytoplasmic clearing that should not be confused with GI tract contamination, nuclear size variation, or really anisonucleosis, and then the complete absence of nuclear polarity. In some cases, ancillary anisochemical stains are actually very helpful, such as P53, SMAD4 in the setting of a solid lesion, can truly be supportive of an adenocarcinoma when aberrantly expressed, or rather diffusely lost. The basis of P53 and SMAD4 are really actually the most common genomic alterations that are characterized by PDEC, and these stains represent really surrogate markers of their genomic alterations in the respective genes. Here's another example of an FMB with actually a necrotic background. And because of that background, it's certainly suggestive of adenocarcinoma, but to many observers, the glandular epithelium ranges from reactive to maybe suspicious for malignancy. And again, this is where the application of immunohistochemistry, or understanding the molecular genetics of pancreatic cancer, and that being SMAD4 alterations, and in this case SMAD4 loss, with an actual positive internal control that typically the inflammatory infiltrate, or sometimes fibrosis, lymphocytes in general, can help establish the diagnosis of an adenocarcinoma. Now, another helpful stain that I find, or at least our group has found, is that we've implemented recently is the application of ARID1A. ARID1A is lost in about 10% of pancreatic ductal adenocarcinomas, along with cholangiocarcinomas as well, and loss of expression can be seen in a subset of pancreatic cancers and really help in making the diagnosis for these subset of cases. Interestingly enough, they're often mutually exclusive from SMAD4, so if SMAD4 is not helping, ARID1A may. Now, I briefly discussed chronic pancreatitis kind of peripherally and more generalistically, but it's really important to kind of hone down on one specific entity when it comes to chronic pancreatitis, and that's autoimmune pancreatitis, or AIP. And classically, the diagnosis is really based on FNAs alone, and is really essentially impossible. Can't really make a diagnosis of autoimmune pancreatitis by FNAs. But the ability to get really actual tissue, and that being an FMB, makes it really easier to make a diagnosis of autoimmune pancreatitis. And briefly, autoimmune pancreatitis comes really in three flavors. Type 1 is also known as lymphoplasmacytic sclerosing chronic pancreatitis. That's really IgG4 associated. Type 2 is associated with typically inflammatory bowel disease. Also still an autoimmune condition nonetheless. In the US, by far, type 1 outnumbers type 2. And type 1 is characterized by prominent lymphocytes, plasma cells, along with a storiform fibrosis, specifically in cases that really have long-term injury, as shown here. Of course, there's that provisional type 3 now that we're starting to recognize, and that's with immune checkpoint inhibitors. And so really your immune checkpoint inhibitor type pancreatitis that can occur. Typically, we don't get biopsies from those because it's kind of actually a thought process in the clinical setting itself. Now, the histologic findings on FMBs closely resemble those seen in resection specimens, where again in type 1 autoimmune pancreatitis, you have that lymphoplasmacytic infiltrate. That's truly obvious. It's not going to be hard to find. It forms really a rind around the ductal system and eventually, or actually essentially permeates the ducts, causing a ductitis. And as I mentioned before, there's really a prominent fibrosis that ensues thereafter. So it's really a multi-step process itself, where you find that the chronic inflammation comes first, and then the fibrosis sets in later. Type 1 AIP is a T-cell mediated disease, and therefore it's not surprising as it results in eventual venulitis, tissue destruction of the acinar parenchyma, and then eventually the veins that are really where the chronic inflammation emanates from them. And it's also known as obliterative phlebitis. Additionally, something that is not really well recognized, but really is seen actually in both patients' blood as well, and that's the presence of eosinophils. We often do see eosinophils actually scattered throughout the pancreatic parenchyma, and you can actually track that with peripheral eosinophilia in the patient's blood, and that is a pretty common finding in type 1 autoimmune pancreatitis, but doesn't really get a lot of traction when it comes to the pathology itself. So going back to our case of a 69-year-old male with jaundice and a 3-centimeter pancreatic head mass, along with peripancreatic lymphadenopathy, the FMB consisted of multiple tissue fragments, a pancreatic parenchyma with lymphocytes, plasma cells, eosinophils, along with fibrosis in the background. Moreover, there's this paravenular chronic inflammation consistent with venulitis. And hopefully the case is a little more straightforward now and going through that systematic approach, where in the last few minutes we've talked about type 1 AIP. I would, however, like to underscore that type 1 AIP is associated with elevated serum and tissue IgG4 levels. However, elevated IgG4 is not really a requirement for the diagnosis. Instead, I really rely on the lymphoplasmacytic infiltrate and at least either a ductitis or a venulitis. IgG4 staining can be supportive of the diagnosis. However, really good cutoffs of IgG4 with FMB material has not been actually established. Those were really based on surgical pathology or on biopsies of the ampulla, which, to be honest, that data on the ampulla is now considered false. Moreover, when guiding clinicians in the setting of really potential AIP, I always ask them to sample the periphery of the pancreatic lesion, as that's the best place to identify venulitis to aid in the diagnosis. So when you do have a clinician that's there, maybe even doing a ROSE, and they are questioning AIP type 1, make sure they sample the periphery of the lesion, not just in the heart of the lesion itself, because that's where you're going to pick up that venulitis. So to recap, traditional cytologic features really have that drunken honeycomb look of nuclei that often have overlap, loss of polarity, and the presence of regular nuclear membranes are truly supportive of pancreatic ductal adenocarcinoma. But the assessment of FMBs requires the combination of cytopathology and surgical resection material, where adenocarcinoma is often found floating next to the tissue cores as opposed to within them, and exhibit both architectural complexity as well as cytologic changes itself. Those cytologic changes include really cytoplasmic clearing that are distinct from GI tract contamination, really shouldn't be confused with that at all, and nuclear abnormalities with loss of nuclear polarity, similar to what we really find when it comes to looking at the classic cytologic findings itself. And finally, because the needles have increased tissue yields, ancillary immunohistochemistry and molecular testing are now possible and actually quite helpful. I find that the P53, SMAD4, and more recently ARID1A stains to be actually helpful for our group in trying to establish a diagnosis. Now, these findings contrast that of chronic pancreatitis that retains that lobular architecture of the pancreas. Really utilize your understanding of the surgical pathology when it comes to looking at these FMBs, because it could really help you a lot. And that's really looking for those round open lumina of benign ducts, both intralobular fibrosis that is often devoid of ductal epithelium. Really helpful findings in establishing the diagnosis of really an absence of pancreatic cancer. And in most of these cases, the really more common phenotype that we're really looking at is type 1 AIP, which requires really, in my mind, at least 2 of 3 criteria. That includes lymphoplasmacytic infiltrate, ductitis, and or a venulitis. Typically that involves a lymphoplasmacytic infiltrate and either a ductitis or venulitis, but not necessarily both that are present. And so I usually get one or the other, but that lymphoplasmacytic infiltrate should be the first step, and then you're just looking for the other one or the other. Again, IgG4 can be used to support a diagnosis, but it doesn't truly make the diagnosis, and you can see IgG4 positive cells in the setting of pancreatic cancer. So just be a little careful of using the IgG4 to help you make that diagnosis itself. Let's try another case, 65-year-old male with a similar history as a prior, but now with a much larger mass, measuring 10 centimeters, involving both the pancreatic head and uncinate. Interestingly, the patient also presented with peripheral petechia, involving his extremities, his legs, his arms. In fact, one of the medical students saw him and mentioned that he looked like he had been in really a fight. It seemed like he had numerous bruises all over his arms and legs. Enzyme studies were done and essentially negative, and an FMB was performed and revealed large clusters really of sheet-like neoplastic cells with a dirty necrotic background. At higher magnification, the neoplastic cells resembled normal acinar parenchyma with rosette and ribbon architecture, but the neoplastic cells were also somewhat interanastomosing in and out. Now, going back to, again, that differential diagnosis, really that top-down kind of thought process. And obviously, it includes pancreatic ductal adenocarcinoma and chronic pancreatitis, but it's also, remember, that latter set of neoplasms that often consists of sheets of neoplastic cells, but with distinct histologic, immunohistochemical, and truly molecular features overall. And at the top of our list is really acinar cell carcinoma, which typically affects older adults similar to PDAC and closely resembles their cell of origin, acinar cells, by maintaining their that rosette architecture and the criteria for their diagnosis, which typically is evidence of exocrine function or enzyme production itself. And that includes trypsin, chymotrypsin, and lipase. Now, with improvements of FMBs, the diagnosis of these neoplasms is really much easier. One can appreciate the histologic features of acinar parenchyma, distinguishing it, acinar cell carcinoma specifically, distinguishing it from acinar parenchyma, normal acinar parenchyma from the pancreas itself. That would normally be seen actually in surgical specimens, where you see really devoid or really pushing away of all the ductal epithelium itself, or really destruction of that. Moreover, there's often really sufficient material for ancillary studies to show exocrine enzyme production, like trypsin. But findings that I keep in the back of my mind when considering an acinar cell carcinoma is, first of all, presentation. Acinar cell carcinomas typically affect the body and tail of the pancreas. They're typically large masses. They're not incidentally identified 1 centimeter masses. They're often on the order of 5 to 10 centimeters. And again, about 10% of patients actually present with excessive lipase production, resulting in subcutaneous and intraosseous fat necrosis, paniculitis, as well as polyarthritis. That's typically due to the fact that the enzymes from acinar cell carcinomas, like trypsin, chymotrypsin, lipase, are extending into the vascular system and then literally eating away at the periphery of the patient's body. It occurs about 10% of patients overall. I'd like to reiterate that demonstration of acinar differentiation is also essential to the diagnosis, and that's with immunohistochemical stain confirmation like trypsin. And then more recently, BCL10. Really, BCL10 has gone really well in general. It's really an exceptional stain for most of our cases. I would say I've been having issues with our trypsin stain more and more post-COVID. It's just the clone of trypsin has not been working very well, but BCL10 is astounding. But that really leaves an absence. I love to see 2 stains that help support the diagnosis. Much like with neuroendocrine tumors, we often use synaptophysin, chromo, maybe INSM1. I'd like to see at least 2 stains, and so we've been on the search for looking at additional stains. Certainly, I think a great stain is carboxypeptidase A1, but a nice nuclear stain, especially when you're dealing with FNAs or even FMBs, is GATA4. GATA4 is a transcription factor necessary for terminal differentiation of acinar cells, and is actually required for early development of acinar cells. And it stays retained in acinar cell carcinomas, even in more of a dedifferentiated look. And so our lab has actually combined both stains, GATA4, that's in brown, and CPA1, that's cytoplasmic staining in red. It's just a nice double stain to use for not only our resections, which are typically very straightforward, and we can use trypsin or BCL10, but really the utility of the dual stain itself, which is now starting to get some traction in some other labs, is the fact that you can use it on FMBs, and you don't have to use just an extra slide to get to the diagnosis. It's just nice to conserve on the number of slides that you have. But it is also important to remember that acinar cell carcinomas harbor actionable alterations such as BRCA, POLB2, and thus susceptible to platinum-based regimens like PARP inhibitors, along with PARP inhibitors. Further molecular driver alterations include fusion genes such as BRAF, RAF, and RET. Similar to lung cancers, these fusion genes are actionable from a therapeutic perspective for patients with acinar cell carcinomas, and we've seen some great responses, especially when it comes to RET fusion acinar cell carcinomas. So something to keep in the back of your mind, that this may be an important aspect of these patients that getting acinar cell carcinomas, that they might have actionable targets, and something to clue you in to your oncologist, or at least to consider doing molecular testing on them. Another acinar neoplasm that deserves attention are really pancreatoblastoma. These neoplasms have a bimodal age distribution, to include 2/3 children, 1/3 adults. The hallmark, the histologic hallmark of pancreatoblastomas is these squamoid corpuscles, or nests, that are composed of loose aggregates of large spindle-shaped cells, really sometimes frank squamous differentiation, with or without keratinization. I know it sounds a bit odd, but those squamoid nests are really easy to capture on FMBs. I don't know what it is about them. It's harder to see them sometimes on really surgical resection material, but they seem to stand out on the FMBs. They just love to come out in general and then stay as a nice group of cells. And essentially, they remain intact, and similar to surgical specimens, they can really have these nice optically clear nuclei also in the squamoid nest itself. Actually, a nice fun fact for trivia is that the optically clear nuclei in pancreatoblastomas are filled with biotin. And actually, when we were doing a lot of biotin antibodies or conjugated antibodies in general, they would always suck up all the immunostain itself. But it's still a really nice, helpful feature to see that to find the squamoid nest, is that there's optically clear nuclei. But they also are immunochemically positive for beta-catenin. Interesting enough, beta-catenin is positive only in the squamoid nests themselves, and this is associated with APC or CTNB1 mutations. So things to think about in your differential, but again, the beta-catenin really would only be nuclearly positive within those squamoid nests, but not within the remaining portion of the neoplasm. But obviously, when you talk about beta-catenin and you talk about the pancreas, you have to think about another neoplasm, and that's solid pseudopapillary neoplasms, which would also enter the differential diagnosis of a sheet-like growth pattern and cytologically composed a papillary branching architecture of neoplastic cells. These neoplasms need to be confirmed from an immunochemical perspective, and they mimic acinar cell carcinomas, pancreatoblastomas, along with other neoplasms of the pancreas. But molecularly solid pseudopapillary neoplasms harbor recurrent mutations in exon 3 of CTNB1 or beta-catenin that results in really the diffuse nuclear expression of beta-catenin within these neoplasms, as opposed to the squamoid nests, which are just localized to those squamoid nests in a pancreatoblastoma. However, I find it personally challenging to evaluate beta-catenin, and so many labs have now really fluctuated to LEF1. LEF1 is really a nuclear transcription factor, much easier to deal with when you're dealing with FNB cell blocks or FNAs in general, where you can see nice nuclear expression diffusely present within a solid pseudopapillary, and it's also positive in those squamoid nests in a pancreatoblastoma. In addition to exocrine neoplasms, endocrine neoplasms should always be in your differential, and those include specifically pancreatic neuroendocrine tumors. Often adopt an organoid architecture, ribbons, trabecula, and or nests. Stains are similarly important as establishing the diagnosis. That includes synaptochromo, and then INSM1 can certainly be helpful, especially if it's a nuclear stain itself. But that's really just half the battle, as you know. When it comes to neuroendocrine tumors of the pancreas, it's all about grading, and that's basically counting Ki-67, mitotic index in general, and establishing that WHO grade itself. And we'll talk a little more about that, but it's actually important for operative planning for a subset of neuroendocrine tumors of the pancreas. Lastly, I can't leave the differential diagnosis without a few words about pancreatic neuroendocrine carcinomas, and we'll get into that in a little more detail as we go through this talk. But obviously, with a high Ki-67, typically on the order of greater than 55%, but also positive for endocrine markers, most often synaptophysin and INSM1, and rarely chromogranin A. So let's return to our case of a 65-year-old male with 10-centimeter pancreatic head and uncinate mass that had peripheral petechia and an FMB of a cellular neoplasm consisting of sheets of neoplastic cells, organized in interanastomosing ribbons, rosettes within a dirty background. Immunochemical stains were performed and revealed the neoplasm was positive for BCL10, but not trypsin. As I mentioned, trypsin has just not been very successful in a lot of labs, and the clones currently have just not been very well good in general. In addition, interesting enough, the neoplasm was positive for synaptophysin, hence the expression of both exocrine enzymatic markers as well as potentially synaptophysin being an endocrine marker itself. Now, it's well known that, and actually it's been described many times, and you'll read in the WHO, the Blue Book itself, that acinar cell carcinomas can express synaptophysin. It's well known, and it's an interesting finding nonetheless. In fact, you can sometimes even see patchy INSM1 in acinar cell carcinomas, but typically not diffuse. But this should not be a deterrent for just diagnosing an acinar cell carcinoma. But obviously, this always brings the question, is this a mixed neoplasm? And therefore, really a good segue to the concept of MNN, that being mixed neuroendocrine, non-neuroendocrine neoplasms, which is actually truly separate from mixed acinar and neuroendocrine carcinomas, two different diagnostic categories. As per the WHO, MNN are really neoplasms exhibiting at least 30% of both endocrine and exocrine components, but they have to be distinct and separate. Typically make the diagnosis of MNN on surgical resections. I would never make the diagnosis of MNN on an FMB. It's just not worth it. 30% is arbitrary, and that is really kind of the WHO rule when it comes to the GI tract. 30% is typically where we cut off when we talk about distinct patterns, but really making the diagnosis, as I mentioned before, just not possible. I do the same thing with mixed neoplasms when it comes to mixed acinar and neuroendocrine carcinomas, as these neoplasms are very similar. The difference between a mixed acinar and neuroendocrine carcinoma itself is that you have basically the same, really, histochemical stains themselves overlapping that neoplasm. They can show both truly a number of acinar positive markers as well as diffuse expression of not only synaptophysin, but maybe even chromogranin and sometimes even INSM1. That's a true mixed neoplasm. Very different from a MNN, which should be distinctly different in two different areas. So just to recap, because it's a lot that we've gone through in that case number 2, and really underscoring the advantages of next generation needles themselves and their ability to not only evaluate morphology, but the ability to perform ancillary studies. I think that's really important when you have these nested neoplasms or these sheet-like growth patterns itself of cellular specimens themselves to establish that differential diagnosis through immunohistochemical stains. It's not going to just be morphology. And that's where you really want to employ a limited panel of stains that can be performed that includes, I would say, synaptophysin, chromogranin, along with even INSM1. I think it is a valuable stain as long as you understand its limitations. Also, BCL10, and then for us, we've integrated GATA4 and CPA1 into our workflow itself as a dual stain. As for acinar neoplasms themselves, like acinar cell carcinoma and pancreoblastoma. And then similarly, beta-catenin and LEF1 are very useful in establishing the diagnosis of solid pseudopapillary neoplasms. However, I'm more biased. I like LEF1 much better than I do beta-catenin. I know it's a little bit odd, but the Ki-67 can help actually in the appropriate setting, especially when it comes to high-grade neoplasms like neuroendocrine carcinomas, even acinar cell carcinomas where the Ki-67 is quite high. If you have something that's really a low Ki-67, then you start thinking about neuroendocrine tumor itself. So to further really help classify neoplasms, that being solid cellular neoplasms, I think it's important just to go through a couple more cases before I give it off to Chris. But really, next case is a 54-year-old female with a history of breast cancer, and upon surveillance imaging found to have a pancreatic tail mass that measured actually about 1.9 centimeters. Both an FNA and FMB were performed. The FNA on diff-quick was really hypercellular within a bloody background composed of monotonous population of cells. These cells had variable amounts of granular cytoplasm, a dense and eccentrically really placed nuclei, really had a plasmacytoid appearance. On Pap stain, as on the bottom right, the nuclei are round, uniform, inconspicuous nucleoli. Similarly, the FMB was filled with sheets of neoplastic cells that maintained really a plasmacytoid appearance. And of course, with a history of breast cancer, metastasis had to be excluded, but the neoplastic cells were were positive for synaptophysin, chromogranin A, but negative for mammoglobin, GCDFP, and the hormone receptors themselves. In addition, a Ki-67 showed a low proliferation index of only 2%. Now, overall, I think that the diagnosis is pretty straightforward in this case. It's a well-differentiated pancreatic neuroendocrine tumor, and based on a low Ki-67, insignificant mitotic index itself, classified best as a WHO grade 1. Now, from a diagnostic perspective, the case is, again, cut and dry, but there are a number of nuances that really require consideration. And as many of you know, PANETs, or pancreatic neuroendocrine tumors, are increasingly being encountered in clinical practice, and their increasing incidence itself is really due to frequent abdominal imaging. And hence, it's not surprising that the majority of PANETs identified are typically clinically indolent, but a subset can behave aggressively and metastasize widely. The trick is to identify and treat those bad-acting PANETs themselves. And so based on multiple studies, current prognostic parameters include tumor size, especially those at a cutoff of 2 centimeters and larger, and WHO grade. And that's where we get stuck when it comes to WHO grade in defining or identifying those G2 and G3 PANETs when they're still small. Size is obviously relatively easy. That's based on imaging, but then your gastroenterologist is going to ask you about WHO grading. Now, I would say that the problem with WHO grading on a neuroendocrine tumor, especially even on an FMB, is obviously sampling. Sampling is always going to be our detriment itself. And so I typically leave a comment about sampling be an issue if I have a grade 1 neuroendocrine tumor. But understandably, if it's a grade 2 or even a grade 3 that's small, which can occur in a subset of neuroendocrine tumors that are less than 2 centimeters, that is an indication for surgery, and hence why they want to have that data. But we're also evaluating other biomarkers that truly help us in determining prognosis with pancreatic neuroendocrine tumors, and those are ATRX and DAX. And we've discussed really in other society meetings, like Pancreatobiliary Society meetings, as well as even the neuroendocrine tumor societies themselves, and the utility of ATRX and DAX. And these are really upcoming markers itself. I think that they've started to gain traction, mostly ATRX when it comes to gliomas, but now more so DAX itself in addition. Where in our experience and others as well, if you have loss of ATRX or DAX, despite a Ki-67 maybe of grade 1, you can still have shorter disease-free survival and shorter disease-specific survival for these patients. They often metastasize, and they metastasize widely over the patient's lifetime. And so actually very helpful prognostic biomarkers that are starting to gain some traction, especially in FMBs, as we try to help establish really prognostic biomarkers that are relative to their biology or their molecular signature themselves, and not just based on size or Ki-67, which I think, in my opinion, I hate doing Ki-67. I don't know about you, but at least with these markers coming through, they might be a better prognostic signature than just Ki-67 alone. So how do we put DAX and ATRX in perspective in this case? If you remember, again, this case 3 was a 1.9 centimeter pancreatic neuroendocrine tumor that was grade 1, and per, again, the NCCN guidelines, has a low likelihood of metastatic spread based on tumor size of less than 2 centimeters and a WHO grade theoretically of 1. However, the patient's neuroendocrine tumor also demonstrated loss of ATRX and preserved expression of DAX. And at the University of Pittsburgh, we act on the loss of ATRX. We've seen the data itself where it can actually promote metastasis. We don't know the mechanism or the molecular mechanism itself, but certainly a bad prognostic feature. And so with that information, the patient made an informed decision to undergo a distal pancreatectomy, which revealed the G1 neuroendocrine tumor, so no surprise, 1.9 centimeters, basically as expected, as we had discussed itself. But there was microscopic metastatic disease in one of about 16 lymph nodes. And so one could argue that certainly we've maybe caught it in time. It's now hit one of the lymph nodes, but who knows what to say. But one of the great things about this is now we're starting to gain traction again in ideas and understanding the prognosis of these neuroendocrine tumors, that there are molecular markers that will underpin how they act overall in this patient. And so why don't we go to the last case so I don't try to confuse you completely about neuroendocrine tumors. It's probably good to stay on the same theme when we talk about neuroendocrine tumors. And so in this case, we have a 67-year-old female with a history of a grade 2 pancreatic neuroendocrine tumor that underwent a distal pancreatectomy. As recommended after surgery, she was kept on yearly surveillance scans to look for recurrence, and a recent dotatate scan that looks really for SSTR2 and SSTR5 expression that's common in neuroendocrine tumors detected a 1.4 centimeter mass in the remnant pancreas, so what was left of the patient's pancreas itself, as well as detected a 1.2 centimeter liver lesion in addition. The liver lesion was easier to sample of the two lesions, so our GI gastroenterologist, sampled that. And here's the FMB of the liver, and the same needles can be used not only for the pancreas, but they can use the same needles also to evaluate the liver itself, especially if it's close enough within the area of the EUS itself. And it was involved by a cellular and sheet-like neoplasm itself, and both it had a nested and a thick trabecular architecture, and also stained diffusely with synaptophysin, was also positive for INSM1, but the Ki67, as you can appreciate, was very high, on the order of about 84%. Now, other markers were done, and really, again, I'm trying to hone in on the fact that we're doing panel testing, and that's BCL10, trypsin, GATA4 itself with CPA1, all negative, along with LEF1 and beta-catenin. And basically, that really whittles down our differential diagnosis to really an endocrine neoplasm of the pancreas, specifically either a well-differentiated neuroendocrine tumor like a G3 or a poorly differentiated pancreatic neuroendocrine carcinoma. And we've covered PANETs in the previous case, but really haven't gotten the opportunity to really talk about neuroendocrine carcinomas. And I think the first step about this is when we talk about tumors versus carcinomas, it's about nomenclature. And that nomenclature involves differentiation and grade. The current convention is that all pancreatic neuroendocrine tumors are well differentiated, and hence PANETs should show histologic features analogous to the pancreatic islets of Langerhans. Moreover, these tumors are classified into 3 grades, grade 1, grade 2, and grade 3, based on mitotic index of 2 to 2 millimeters, as well as Ki67 cutoffs of 3 and 20%, respectively. In comparison, poorly differentiated neuroendocrine carcinomas are cytologically very different from well-differentiated neuroendocrine tumors. The neoplastic cells are often in background necrotic debris and are organized in clusters, sometimes single cells, along with inconspicuous nucleolus, but significant pleomorphism in the nuclei itself, as well as a significant amount of anisonucleosis in addition. As per the WHO, poorly differentiated neuroendocrine carcinomas are not graded, but rather subtyped as to large cell or small cell. Large cell pancreatic neuroendocrine tumors, carcinomas, are certainly more common, but because they are rarely resected cancers themselves, subtyping has been a challenge and really based on FNAs alone or sometimes now FMBs. But that being said, it's become a little easier to do this on FMBs when you're getting more and more material overall. But the real issue for most pathologists is understanding the distinction between the highest grade of a pancreatic neuroendocrine tumor, that being G3 PANETs, and poorly differentiated pancreatic neuroendocrine carcinomas. First, distinguishing between these neoplasms is important, as G3 PANETs are often treated with surgical intervention and chemotherapy thereafter. That includes somatostatin analogs, alkylating agents, as well as PRRT. While chemotherapy is really the option or really the mainstay of treatment for carcinomas of basically pancreatic neuroendocrine carcinomas itself. It includes actually a platinum-based regimen and radiation, especially for small cell carcinomas of the pancreas. Hence, separating these neoplasms is important. You can't just get away by calling it just a pancreatic neuroendocrine neoplasm. Next case, you really want to do your best in subtyping them. And so the problem, however, is subtyping these lesions when they have a high Ki67 is the distinction between these two entities. It can be challenging. Many G3 well-differentiated neuroendocrine tumors, again, show resemblance of the islets of Langerhans, but can demonstrate overlapping histologic features of that with poorly differentiated neuroendocrine carcinomas. And between these two examples, without really additional data, I can tell you that one of these two neoplasms is a G3 PANET, and the other one is a poorly differentiated neuroendocrine carcinoma. And the question really is, which one is which? And so one of the things we know about is that we started to characterize neuroendocrine tumors, we've characterized neuroendocrine carcinomas, and so there are clues to understanding what is what when it comes to the histology, where we can maybe leverage some of that molecular data to help us distinguish between what a pancreatic neuroendocrine tumor is and what a pancreatic neuroendocrine carcinoma is. And that's what many of the groups that we've actually been involved with have been sequencing, and we've gotten over about 900 neuroendocrine neoplasms of the pancreas with approximately 200 that are neuroendocrine carcinomas. And what we've found, and as well as others and confirmed, is that neuroendocrine tumors often have genomic alterations that you would expect when it comes to G3 PANETs, and those are MEN1. MEN1 is very common in neuroendocrine tumors, but so is DAX and ATRX, which we talked about were poor prognostic features. While in contrast, when it comes to neuroendocrine carcinomas, they're often devoid of MEN1, as well as DAX and ATRX, and instead often harbor alterations, specifically in RB. Now, there is one caveat that I think that the literature is still very murky on, and that's P53 alterations. P53 alterations can occur in G3 PANETs as well as neuroendocrine carcinomas, and is not a marker that I use constantly to really hang my hat on. You can have p53 alterations occur, especially in metastatic G3 pancreatic neuroendocrine tumors. Now, going back with that knowledge and understanding these two cases based on morphology, knowing that one is a G3, one is a neuroendocrine carcinoma, we kind of go through those steps of really immunohistochemistry as really a cheaper surrogate to molecular testing itself, where we go through, again, that knowledge of understanding that ATRX and DAX, which result in loss of protein expression when mutated, are excellent markers of well-differentiated pancreatic neuroendocrine tumors as opposed to poorly differentiated neuroendocrine carcinomas themselves. Where in this case, you can see that case A has loss of ATRX expression, which would be consistent with a neuroendocrine tumor. The issue, however, is that the preserved expression of ATRX and DAX doesn't help you. Unfortunately, a subset of neuroendocrine tumors, as well as neuroendocrine carcinomas, as you would expect, can still have retained expression. And so the question in this case is, what is case B? Is it a tumor or is it a carcinoma? And that's where another set of stains will help, and that's with RB. Looking at RB1 loss itself, and that being reflective of RB1 mutations, typically when you have complete loss of RB1 itself, it will be associated with a neuroendocrine carcinoma. And so putting everything together with our panels of stain, case B is a neuroendocrine carcinoma. Now, before I leave the differential diagnosis, I do want to stress that there's additional helpful clues. It's not always about the stains, it's not always about morphology, but it's also about understanding the patient itself, really the clinical history, let's say. And so that being the clinical findings that would favor a grade 3 well-differentiated neuroendocrine tumor would be really an incidental presentation with elevated serum chromogranin A levels, as with most pancreatic neuroendocrine tumors. In contrast, patients with poorly differentiated neuroendocrine carcinomas often present with abdominal pain, jaundice, weight loss, pancreatitis, similar to other exocrine neoplasms like acinar cell carcinomas and pancreatic ductal adenocarcinoma. As for serum studies, neuroendocrine carcinomas often are really remarkable for elevated CA19-9 and CEA, where that contrasts that of neuroendocrine tumors. In addition to clinical presentation, I can't stress enough the importance of a thorough pathologic examination and really a pathology history itself. While really controversial, poorly differentiated neuroendocrine carcinomas are currently considered to not arise from a low-grade component like a neuroendocrine tumor itself, but arise de novo from the exocrine pancreas itself, typically acinar cells or ductal cells, while neuroendocrine tumors, that being grade 3, are usually a progression of either from grade 1, 2, then 3 itself. This can be difficult when dealing with biopsies, but if the patient had a prior pathologic specimen that exhibited a low-grade pancreatic neuroendocrine tumor, more than likely it evolved to a G3 instead of really evolving to a neuroendocrine carcinoma itself. And finally, as I reviewed, I find that a limited immunohistochemical panel can be very invaluable in dealing with these types of lesions that consists of ATRX, DAX, RB, and then again, cautiously P53. You'll see that P53 in literature can be used, at least in the right context. If you certainly see ATRX or DAX loss and you see loss of P53 or a barren expression of P53, follow that ATRX and DAX. Those are going to be your better markers. Same goes with the RB itself as well. So let's go back to our case, 67-year-old female, the history of a grade 2 well-differentiated neuroendocrine tumor, status post-distal pancreatectomy, now presenting 5 years later with 2 masses, one in the remnant pancreas and another one in the liver. And a biopsy of the liver lesion was performed using a beveled FNB and revealed a cellular neoplasm organized in nest, trabecular architecture with diffuse expression of a neuroendocrine markers, and Ki67 was through the roof, over 80%. Now, as we discussed, a immunohistochemical panel was performed that included P53, which was clearly aberrant, often referred to as the missense pattern itself. I don't like the terminology, of missense pattern. I'm a molecular pathologist also by training, and so I know that P53 aberrant expression can occur in a number of other alterations, not just missense, but nonetheless, certainly aberrant expression of P53, correlative of a mutation in P53. But there was also complete loss of ATRX. And again, ATRX should trump the P53 itself. And so this is a metastatic, well-differentiated pancreatic neuroendocrine tumor, grade 3. Again, knowing the patient's history, knowing that P53 can be seen in both lesions, and the fact that you have ATRX loss, really consistent with that. But to give you additional data, we went back and we looked at the patient's primary neoplasm back when the patient had a distal pancreatectomy. That was pulled. And it also showed ATRX loss. So consistent that ATRX loss is really an early genomic event, typically occurs in the primary pancreas itself, and that P53 actually didn't show aberrant staining. And often we see the P53 aberrant staining typically in the MET, and seeing that the genomic progression of these neoplasms is likely occurring, P53 being later event as opposed to neuroendocrine carcinoma being an early event. So I've gone through a lot, and my time is fleeting, and I want to give Chris his time. And so really armed with the information that we have when it comes to solid lesions, it's really important to keep in the back of your mind morphology, immunostains, and non-molecular testing. It's really going to be helpful in really understanding the molecular genetics and surrogate markers that we're using. And to recap really what we've already talked about, really these needles themselves and understanding the morphology, that you have to really utilize what we understand from the surgical pathology, not just the cytopathology. And really the tissue yields themselves really are making it amenable to doing immunohistochemical stains like P53, SMAD4, ARID1A, very helpful in general in making the diagnosis. But these FMBs also have a lot of cellular material, probably for cellular neoplasms of cells, like acidocytous carcinomas, solid pseudopapillary neoplasms, pancreatic neuroendocrine carcinomas, where you can do a limited panel itself. Just picking the right stains is the most important part, and understanding the utility of those stains as well as some of the limitations, like IgG4, I think is a hugely limited stain overall in making a diagnosis. I would underscore also that DAX and ATRX as prognostic biomarkers really going to probably hopefully supplant that when it comes to Ki-67, at least in the preoperative setting, not in the postoperative setting, but it's going to be very important to have those online. You already have ATRX if you're doing gliomas in your lab, or at least in a sister lab. That will be helpful, and eventually DAX will kind of take itself as well. And then the distinction between G3 well-differentiated neuroendocrine tumors versus poorly differentiated pancreatic neuroendocrine carcinomas certainly can be challenging. But I would admit that really looking at not just the immunohistochemical features, morphology, but also relying on imaging findings, prior pathology, those can really be helpful overall itself, taking that patient in the whole context and getting as much information as possible before rendering a diagnosis. And with that, we'll pass it off to Chris. And we'll deal with questions after the session.
Hi, I'm Chris Vandenbush. It's nice to see you all. So just diving right into case 5. So case 5 is a 44-year-old female with a history of breast cancer. Had a staging CT scan that identified a 3.1 centimeter cyst within the pancreatic head. EUS confirmed the presence of this cyst was multiseptated, and FNA yielded a thin fluid, which was submitted for cytopathologic examination and molecular testing. And so here is the preparation of the cyst fluid for microscopic analysis, and you can see that the specimen is relatively paucicellular, so not something that we're surprised about when we FNA a cyst. It's not always very rewarding. We don't get a lot of material. And you might see some rare kind of groups of cuboidal cells. It's hard to tell if that's small fragments of GI contamination or actual part of the cyst lining. Some not acellular debris, but no definitive cyst lining, no evidence of cancer, high-grade dysplasia, anything like that. And so this kind of brings us into the cystic lesions. Artur covered a lot of the solid lesions, which are very exciting, a lot of neuroendocrine stuff there. Cystic lesions, I'm a cytologist, so people get fluid, they send it to us. I like to look at cells, but then I get fluids, so sometimes there's cells in the fluid, and that's great. So how do we deal with these cystic lesions on FNA? So just kind of setting the stage a little bit, there's about 60,000 new cases of pancreatic cancer in the United States, and most patients unfortunately succumb to their disease. And about 9,000 of those arise from mucinous pancreatic cysts, whether that be intraductal papillary mucinous neoplasms or MCMs, mucinous cystic neoplasms. However, there's a large number of Americans who have a pancreatic cyst, more than 6 million. So, might not be discovered necessarily, might be incidentally discovered eventually, but there's a lot of people walking around with pancreatic cysts. And there can be a lot of different types of cysts, neoplastic and non-neoplastic. I won't go through them all here, but there's a variety of different types of pancreatic cysts that they may be once they're discovered on imaging studies. So even though there's a proportion of patients with mucinous pancreatic cysts that go on to develop pancreatic adenocarcinoma, about half of these cysts are mucinous pancreatic cysts, but not all mucinous pancreatic cysts will transform into pancreatic cancer. So even though there's a large number of people with these cysts, they don't all need to be removed. Not all patients are going to develop pancreatic cancer from these cysts. So part of the challenge is, in addition to making a diagnosis from a cellular specimen, is being able to identify which patients these are that will eventually progress to cancer so that they can get definitive treatment before they develop cancer. So akin to finding a needle in a haystack. So pancreatic cysts, much like solid lesions, requires a multidisciplinary approach. Certainly you need to take into account as much information as possible because you're not going to get necessarily a lot of information out of the microscopic examination. So taking into account the patient's clinical presentation, imaging studies, the F&A material, and then also as we'll talk about, chemistry on the cyst fluid, analyzing for CEA and amylase, and we'll talk about some other ancillary studies as well. But it's really just recently that now it's not just, okay, patient has a pancreatic lesion, now we can actually sample it through EUS and get material out of it. So EUS allows for high-resolution imaging of the pancreatic cyst and tell us whether there's a relationship to the pancreatic duct, which can also provide information. And as I mentioned, ancillary studies from the cyst fluid, we can do a chemistry for CEA, glucose, amylase, and also do cytologic evaluation. So this kind of talks about some of the more clinical aspects, the location of the cyst, the gender of the patient, to kind of suggest what type of cyst we may be dealing with. So certainly, for instance, an MCN is more likely to occur in a female and more likely to be in the tail, but I won't go through all this in great detail. Viscosity can be increased in mucinous cysts like IPM and MCN. In CEA, chemical analysis can be done on cyst fluid to determine an elevated CEA, initially thought to be above a cutoff of 192 nanograms per mil, is more specific for a mucinous cyst, whereas other cysts tend to have CA levels below that, although it's not completely sensitive or specific, and there's new studies that basically show, the higher the CEA, the more likely it is a mucinous cyst you're dealing with. Amylase tends to be elevated in pseudocysts. It can also be elevated in IPMN. So these chemical markers can be helpful, but they don't give us a complete picture of the cyst. Cytology can be helpful if it's cellular. Again, it's not always cellular, but certainly identifying mucinous epithelium or mucinous contents can be suggestive of a mucin-producing cyst. Whereas other types of cysts, like a serous adenoma, it might have some scant material, some cuboidal cells that might be positive for PAS. And I think we saw a solid pseudopapillary neoplasm in the previous part. And then a pseudocyst, you may have hematoid pigment, histiocytes, crystalloids, things like that. These are things that we can, you'll have this table in the handout, so I won't go through these in too much of great detail, but certainly things that can provide information. So as we mentioned, things that are difficult with pancreatic cysts is oftentimes they can be very scant or have very low cellularity. There can be gastrointestinal tract contamination. So certainly if the cyst is located in the body of the pancreas and you're going through the stomach, you can get foveolar epithelium that's mucinous, and it can be hard to distinguish that epithelium from the lining of a low-grade lining from a mucinous cyst with low-grade dysplasia. So that can be kind of tricky to know whether that contamination is truly contamination or might just be mucinous lining from a mucinous cyst. And as I mentioned, CA and amylase are helpful, but they're not completely specific or sensitive. So in recent years, there have been new studies into pancreatic cyst biomarkers from different institutions to suggest that DNA sequencing is promising as a biomarker assay in cyst fluid. So going back to this table and looking at these key characteristics, we can actually see that now specific gene alterations have been associated with particular types of cysts. And so IPMNs often will have either a KRAS or GNAS mutation, and KRAS mutations can be found in MCNs. VHL alterations are associated with serous beta-catenin gene alterations in solid pseudopapillary neoplasms, and then pseudocysts tend not to have any mutations found in these pancreatic cyst fluid panels. So you can start to develop sort of a table or a list to show when you detect a particular mutation in cyst fluid, it can suggest in the right setting that you're dealing with a particular type of cyst. And so you can kind of create a table like this where if you have a KRAS mutation, it could be an IPMN or an MCN, GNAS mutation associated with IPMN, VHL with serous cystadenoma, and beta-catenin with solid pseudopapillary neoplasm. So going back to this particular case, even though the cytology was nonspecific, it was relatively paucicellular. In this particular case, if it was sent for a panel for testing for mutations, in this case a mutation in VHL was identified, and there were no other genomic alterations, it would suggest that this is a serous cystadenoma. And this is helpful because, I show you one case, but certainly in publications of retrospective analyses at institutions, this is my institution of serous cystadenomas, typically the specimens are very scant, and the diagnoses are often nonspecific, where in this case, there's a 28% of being non-diagnostic, 47% said benign pancreatic ductal or acinar tissue. That's essentially non-diagnostic. Sometimes they were thought to be a pseudocyst, and in some instances they were even suspicious for a mucin-producing cyst, which would be problematic because that could send a patient to surgery who might not actually need surgery for this particular lesion, potentially. So moving on to case 6, this is a 52-year-old female complaining of abdominal pain and had a CT scan that identified a 4.1 centimeter cyst within the pancreatic body. An EUS confirmed the presence of the cyst. It was also multiseptated. And the FNA in this case yielded a thick fluid that was also submitted for cytology as well as molecular testing. So this particular case on the left-hand side, you can see that there's this very thick mucin. It's what I would describe as quote-unquote clean mucin. So certainly you can get mucin from the gastrointestinal tract, but when you see mucin that's really thick, it doesn't really have any acute inflammation or bacteria, and it doesn't really have a lot of kind of mucin, like gastrointestinal contamination in it. It's just this thick, clean mucin. Typically that was taken from a neoplasm that's producing mucin. You're taking it from a compartment that's kind of sterile from the gastrointestinal tract. And so that in itself is very suggestive of a mucin-producing cyst like an IPMN on cytology if you have the correct clinical radiologic setting. However, on the right-hand side, you also have mucinous epithelium that you can see. So in this case, the mucinous epithelium is pretty bland. It doesn't have a lot of atypia in it, so there is no evidence of malignancy or high-grade atypia. So the Kyoto guidelines are kind of an updated guideline system for dealing with mucinous cysts and determining which one of these cysts are something that are problematic. We talked about finding patients that are likely to progress to cancer or have high-grade dysplasia and should have their cysts definitively treated versus those that might need surveillance. And so this is a system, I won't go through all of the flow chart, but to kind of describe which patients should undergo surveillance and monitored by imaging studies versus those that should have definitive treatment or surgery. And what's important for this with regard to cytology is that if high-grade dysplasia is identified, then the patient should have surgery. And so one task for the cytopathologist or the person examining the specimen when you see mucinous epithelium is to determine whether high-grade dysplasia is there or if there's frank malignancy that indicates that the cyst is developed into has a malignant component. And certainly there's a new WHO nomenclature system for pancreas that in dealing with cystic lesions, the diagnostic categories once you've reached a pancreatic neoplasm is whether it's a pan low or a pan high. Does it have low-grade dysplasia or high-grade dysplasia? And similar to what the guidelines just suggested is that a low-grade one that's pan low, you have to correlate with the clinical features. But if you have features of high-grade dysplasia, it requires surgical resection in patients that can tolerate it. So for those that have done this before, it's very challenging. You have a pancreatic cyst, and you can get to a mucin-producing cyst. You feel like in the right setting, what you're seeing is compatible with an IPMN. But all IPMNs have atypia because they at least have low-grade dysplasia. And so cytologically, you're not going to see something completely bland. And so how do you determine whether there's high-grade dysplasia in a specimen? And I don't have a definitive answer for that, but I will tell you that there's at least one publication from Mass General that talks about this, and so I thought it was relevant to mention it. So they did go through retrospectively to look at their specimens, and they found that specimens that had high-grade dysplasia, the cells in the mucinous epithelium were not necessarily larger, but they had enlarged nuclei. So number one, you have high end-to-C ratio, as you see in panel A. And number two, you have nuclear membrane irregularities, which they demonstrate in panel B, so they're not perfectly regular nuclear membranes. And then in panel C, what's demonstrated is actually a hypochromatic pattern of the chromatin. It's a little bit lighter than your typical chromatin, but you can also have hyperchromasia. So basically, any typical chromatin pattern, whether it's hyperchromasia or hypochromasia, both of those are a form of atypia in the chromatin. But I'll tell you that it's very difficult, and a lot of times when I go back and look at our cases, the ones that we called at least high-grade dysplasia ended up just being cancer. They developed into cancer. So it can be quite challenging. And so even though it's important to note high-grade dysplasia or atypia, even if it ends up just being cancer, it can be difficult sometimes to really distinguish that from low-grade atypia on FNA. So some institutions have success with microforceps type biopsies with cysts, and this can allow you to get a larger chunk of the cyst lining as well as sometimes the underlying stroma. And so this is a picture from a colleague at Mass General that shows a mucinous cystic neoplasm where you can see the forceps biopsy got the mucinous epithelium but also had the underlying ovarian stroma, which could then be stained on the biopsy to prove specifically this type of diagnosis. On an FNA alone, you can't get the stroma, so that's why we say mucin-producing neoplastic cyst. We don't know if it's an IPMN or an MCN because we can't see the stroma on FNA alone. So going back to this case, how can molecular testing help? Well, we talked about mutations in KRAS and GNAS, and in this case, this particular lesion had, let's say it had a mutation in GNAS, but it also had copy number alterations that involved P53 and SMAD4. So what does that mean? So if we go back to our table and we can say, okay, some of these lesions are associated with particular alterations in genes. So IPMN can have mutations in KRAS or GNAS. And we talked about making a table of this. And we can actually know that there's this progression of, you have an IPMN with low-grade dysplasia. They all start out with a KRAS or a GNAS mutation. But at some point, what we're concerned about are those that evolve to have high-grade dysplasia. And if they have high-grade dysplasia, they should be resected if possible, because eventually they're going to turn into adenocarcinoma. So is there a way to determine which ones are that have already high-grade dysplasia that we should remove? And so there's studies now that have shown that alterations in P53, PI3 kinase, and PTEN can be associated with, for instance, high-grade dysplasia and or adenocarcinoma and would indicate cysts that should be removed. And so in beginning to make a table like this, you can see that in expanding your panel to include the detection and alterations in other genes, you can identify cysts with at least high-grade dysplasia that should be removed versus those that have not yet developed the high-risk genotype. So there's been different single institutional studies talking about the identification using NGS on cyst fluid to detect these alterations. And what I'll talk about is a study that was done at several different institutions using a method called Pancreas-seq. And this looked at 22 genes at a depth of 1,000-fold for each gene with a limit of detection of 3%. And this particular data came from between the years 2018 and 2021. So this included 1,933 pancreatic cyst fluid specimens from almost 1,900 patients that were prospectively analyzed for genetic alterations. And so this came from 31 institutions. And most of the specimens that were submitted were satisfactory for molecular analysis, so this was about 98% of specimens. So they came from all over the country. And so among the 1,900 cyst patients that were molecularly profiled, the diagnosis follow-up was available for 15% or 251 patients. And this is a distribution of surgical specimens among those patients. So some had IPMNs with advanced neoplasia, so that would be high-grade dysplasia or beyond. And some had just low-grade dysplasia, and there were a variety of other types of entities as well. So looking at the mucinous cysts specifically, there were 186 mucinous cysts on follow-up, 167 IPMNs, and 20 MCNs. And then there were 60 non-mucinous cysts, and there were 5 metastatic neoplasms. So in correlating alterations in KRAS and GNS that were typically associated with mucinous cysts, these alterations were found to have a 90% sensitivity and a 100% specificity for a mucinous cyst. So if mutations in KRAS, GNAS, or BRAF were detected, it was always a mucinous cyst that it was from. If you compare this to just the chemical studies or viscosity, you can see that the sensitivity and specificity is not as great. So looking at fluid viscosity, sensitivity is 77%, specificity is 92%. And looking at elevated CA, sensitivity is 73%, and specificity is 94%. Now looking at specifically advanced neoplasia, and this is where we're really going beyond just even what cytology could tell us because it's so difficult to detect high-grade dysplasia. So looking at alterations in these four genes, you could detect advanced neoplasia with a sensitivity of 89% and a specificity of 98%. So comparing to cytology alone to detect advanced neoplasia, it's very specific. I mean, if cytology thinks there's something that's high-grade dysplasia or cancer, usually it's correct. So specificity is very high at 97%, but sensitivity is not so great, 46%. If you look at imaging data, like is the main duct dilated, so sensitivity 68%, specificity 65%. Or if you look at imaging studies, is there a mural nodule, sensitivity is 45%, specificity is 81% for advanced neoplasia. But if you take into account the fact that cytology is highly specific, you can actually combine it with the molecular data without losing much specificity, but you can increase sensitivity. So cytology can catch a few of those cases that have advanced neoplasia that the panel doesn't detect, but cytology can detect specifically. So combining the panel with cytology can bump up the sensitivity to 93% while only slightly decreasing specificity. Okay, so next we're going to talk about case 7. This is a 78-year-old woman who had several days of dark urine and had elevated LFTs on laboratories and scleral icterus. She had a dilated intrahepatic duct and had a small obstruction in the left hepatic duct. ERCP found a long, smooth stricture involving the entire CBD, common hepatic duct, and right intrahepatic duct. So how are bile duct strictures evaluated? So we can use imaging where we can see let's see, because the guide wire is not going through there, but basically you can see the stricture right there. And so you can actually then even view it with cholangioscopy. And pathology can obtain a sample either through brushing and or biopsy. So I think, is this the brush goes up? Whoops. Do these animations or not? Yeah. Oh, there we go. Too cute not to use, right? So brushing can be a powerful technique, but in the specificity, because it's exfoliative cytology, can be quite high. Again, if you see something that is high-grade dysplasia or malignant on cytology, you have high specificity, 96 to 100%, but unfortunately sensitivity is limited, in many studies 8 to 60%. So in cytology, how do we really assess bile duct brushings? Well, we have a very high threshold for making a diagnosis of malignancy, because there can be a lot of reactive changes that can look quite atypical. And so it can help to look at something that's normal. So on the left-hand side, you have some small fragments of reactive biliary epithelium. It's a small fragment, but the nuclei are around the same size. It has still sort of a honeycomb architecture, versus on the right-hand side, you can see that there's pleomorphic cells. They have irregularities in the nuclear membrane. Some have high end-to-C ratios. They have clumpy chromatin. And something that we really like to use in cytology is the presence of singly present, highly atypical cells. So it's gotten to the point where the cells aren't only atypical, but they start falling apart from each other, and you have single atypical cells in the background. So we typically, at least at my institution, require that before we make a diagnosis of adenocarcinoma on a bile duct brushing. So certainly some laboratories can use FISH, where polysomy can determine that there's a malignancy present. And this can be highly specific up to 100%, but unfortunately it's also limited sensitivity, 10 to 20%. And so there have been studies of this. And so this is something too that you can actually include cytology that's highly specific to with FISH. And so FISH is bumping up the cytology diagnosis by another 10 to 20% without losing much specificity. So the question is, can we also use NGS and apply it to bile duct brushing specimens in the same way that we've done with cystic specimens to increase our sensitivity of detecting patients with malignancy? And so this is another study that took place around the same time, where this took bile duct brushings from 1,500 ERCP specimens. So these were 1,000 brushings and about 500 biopsies submitted for NGS testing. And most of these were sufficient, so only 12 were insufficient for NGS testing. And patients had a follow-up of about 12 months. And follow-up that was available, 658 patients had neoplastic strictures and 501 had benign strictures. And you can see that there were a variety of different types of entities that were found, a lot of ductal adenocarcinomas and cholangiocarcinomas here. And so the NGS panel was pretty specific. It had a 96% specificity, but sensitivity was limited. It was 82%. Not bad, but you wish you could be a little bit better. And as I mentioned before, the cytologic examination of bile duct brushings is very specific. We have 100% specificity, but sensitivity is limited at 49%, does even worse than NGS testing. And so one question is, why isn't NGS testing 100% specific? If you detect a mutation that's really concerning, how come after a year does a patient not have a neoplastic stricture? And this kind of raises a question with a lot of these more highly sensitive methods of NGS testing or sequencing analysis, where you detect alterations that may be way before the follow-up period where the patient develops something concerning, or potentially maybe they have something that is concerning and it goes away at some point and it never becomes a problem. So are there some genomic alterations that are present before you can even have something that's histologically detectable, which might be helpful or it may be problematic. But regardless, because both techniques are very specific, when you combine them, you can bump your sensitivity up to 88% while only slightly lowering your specificity to 96%. So for the last case, we'll talk about a 79-year-old male who's had a status post cholecystectomy, and they have a distal bile duct stent with continued abdominal pain and distal biliary obstruction. So they had a previous biopsy of the common bile duct that was signed out reactive biliary epithelium with erosion and marked acute inflammation. So this time they had a repeat bile duct biopsy that was performed with parallel molecular testing. The molecular panel showed that it was negative for mutations. So no problem, right? Molecular, it's not. But anyway, so here's a biopsy. This is a low magnification. So certainly at low magnification, it can be a little bit difficult to kind of see, what's going on. So we're going to have to look at some of these things at higher power. Similar to kind of what Tur was mentioning, you do start to see some kind of free-floating strips of epithelium, which you can see whether it's a solid lesion or a bile duct biopsy. This can happen a lot of times with these bile duct biopsies or pancreatic biopsies. As you look more closely, you can actually have a good comparison. On the bottom right-hand side, you can see it's kind of well-organized, minimal alterations to the nucleus in this reactive biliary mucosa. Versus on the top left-hand side, you can see that the adenocarcinoma that has a lot of nuclear atypia, there's anesonucleosis, there's hyperchromasia, and there's irregular nuclear contours. This is kind of the free-floating stuff on the top left-hand side. So it's good to be able to look for a comparison between kind of normal reactive and the more to compare to the stuff that looks atypical. And looking more closely, you can even see kind of underlying some of the more normal mucosa, there was actually atypical epithelial cells that are within lymphovascular spaces, as well as kind of colonizing underneath the biliary epithelium. So it's actually even sneaky cells that weren't part of that free-floating adenocarcinoma that could be seen at kind of a closer examination. So similar to what we saw with solid lesions in situations where it can be difficult, this wasn't as difficult cytomorphologically, but just to provide an example, immunohistochemistry can be helpful. So in this particular case, P53 was diffuse in the adenocarcinoma cells, and so that was helpful. And you had a kind of a normal control from the normal mucosa there, which had very weak and patchy P53 labeling. Here's another example. So in this case, you have a biopsy that's very inflamed. There's a lot of acute inflammation. And certainly you have fragments of mucosa that look like they have dark nuclei, that look like they have kind of nuclear irregularity and some anesonucleosis. But there's a lot of obscuring with acute inflammation. And a lot of times with these small biopsies, you see inflammation, you want to hold back quite a bit. It's helpful. Is there something else we can do to kind of make us go beyond just calling this suspicious because there's so much inflammation? So looking even more closely, you can see that certainly there's a lot of concerning atypia, there's nuclear hyperchromasia, there's some cribriform architecture, loss of polarity, and we would like to call it adenocarcinoma, but we hold back a little bit. It's a small biopsy. There's a lot of acute inflammation. In this case, there was the application of SMAD4 immunohistochemistry, and you see that there's preserved SMAD4 expression, a nuclear stain in the normal cells, the non-neoplastic cells, but in the lining of the atypical lining that we see up at the top, you see that the neutrophils are staining, but the nuclei from the atypical cells are not staining. They've lost SMAD4 expression, which is a specific indicator that this is malignant. So you can see it here with a little bit more close, higher magnification. So here's another case where you have a biopsy with the H&E. There's adenocarcinoma, it's an infiltrating fibrous tissue. P53, there's no aberrant expression. However, in SMAD4 shows no aberrant expression, but the marker ARID1A, which is one that Autor talked about previously, there's a loss of expression in these islands that are atypical, and then there's kind of preserved expression in some of the normal cells in the background. So in summary, KRAS, GNAS, and BRAF mutations are highly sensitive and specific for mucinous cysts, especially IPMNs and MCNs. Alterations in P53, SMAD4, beta-catenin, and mTOR genes are reported to be highly sensitive and specific for mucinous cysts with advanced neoplasia. So finally, now we have genes when there's alterations. We can say it's not just a mucinous cyst, but it's one that really needs to be treated definitively. NGS can also improve the evaluation of bile duct strictures, and they can be highly specific for a neoplastic process when applied to bile duct brushings as well as bile duct biopsies. And for both pancreatic cyst and bile duct specimens, certainly incorporating cytology can be helpful because cytology is very specific. It may not be very sensitive, but it can definitely increase the sensitivity of those NGS studies. So with that, we would like to thank you and open up for questions.
So it's a lot in a very short amount of time when it comes to the pancreas and the bile duct. Are there any questions? And if you do have questions, can you come to the mic so that those that are online can hear?
Could you go to the microphone? Thank you.
Thank you for this presentation. My question is about pancreatic neuroendocrine tumor versus grade 3 versus pancreatic neuroendocrine carcinoma. And as you mentioned that the differentiation between these two type of cancer is very detrimental for patients' treatment. If we have a patient, for example, in the presentation is shown that loss of RB gene is only shown in 33% of cases of neuroendocrine carcinoma. So if we have a patient with a both retained Atrix DAX and retained RB gene in immunohistochemistry, first of all, at the level of immunohistochemistry, how do you sign out this case? And then after the genetic workup, does genetic workup always offer an answer for such cases, or still there are cases which are undetermined?
Yeah, that's a really good question, because you're still going to have those cases of uncertainty that are just, unfortunately, they don't classify based on everything that you do. And hence, one of the aspects of looking at the clinical level, looking in to see if does the patient have an elevated CA19-9, or even asking, like, how did this patient get presented? Is it a patient with jaundice, weight loss, putting everything together? Now, that's distinct from pathology, and so, that's where, you have to have the clinical team kind of on board as well, putting everything together on top of that. And again, typically G3 neuroendocrine tumors don't present just sporadic. I mean, honestly, they don't just present without something. I mean, they present incidentally, I should say, but not like little asymptomatically. So I think those are all things. But I've certainly encountered cases where I have not had DAX or ATRX alterations, even molecularly. With the neuroendocrine carcinomas, I've had many cases which don't have an RB loss, as you mentioned. Interesting enough, things that do help then are like sometimes SMAD4. That certainly help. Actually, I've had a few cases of neuroendocrine carcinomas that have SMAD4 loss and CDKN2A loss. That's also been helpful. But the problem with CDKN2A and P16, that is, that you can sometimes see P16 loss in neuroendocrine tumors. Just be a little careful of that stain itself as well. The other thing that's useful from a molecular standpoint is KRAS. We all know about KRAS mutations in pancreatic ductal adenocarcinomas. Neuroendocrine carcinomas also often harbor KRAS mutations. So another finding as well. Sadly, there are going to be cases where you just don't know. And sadly, I think those are the ones that you're going to have to say pancreatic neuroendocrine neoplasm, and then offer a differential, but a very long comment on how it couldn't be classified. Yeah, go ahead.
Thanks. IPMN question. So the examples you showed were quite large, and I'm curious about if there's like a size requirement for them, because presumably a lot of these incidental findings will be smaller IPMNs that are, let's say, a centimeter or something, or sorry, like, 7, sub-centimeter, something like that. Are there size requirements to do NGS and cytology, and are they different, and how does that all come to play with the patient that has an incidental probable IPMN, and there's several million of them probably out there, as you mentioned?
Yeah, to some extent, if they decide to aspirate it, I'm then left with having to assess it. And so, I think certainly a lot of times we're putting this into the clinical radiologic setting. So there's usually some thought that this is an IPMN. If there's not a thought that it's an IPMN, we don't have sequencing studies and this sort of thing. Cytomorphologically, we can't really confirm it if they don't think it is that clinical or radiologically. So I think part of the issue then is having enough cyst fluid for analysis. And so typically I think that, if they're following the guidelines, it's going to be a certain size to aspirate. And then, I think you're going to want at least, ideally it's a mil, but sometimes less.
For us, it's 200. I don't know what yours.
It's the lower limit, right? But
yeah, we can do 100.
100, okay, well. So I guess, ideally we would be confirmed with the fluid. I think they can usually get 100 out of it, depending on what you're asked, what the laboratory is requesting for the.
Yeah, I think that it's going to vary from laboratory to laboratory, like your laboratory versus ours. I think that for us, though, when it comes to triaging.
You might want to, sorry,
yeah. So when it comes to triaging, so I guess the question is, when do you send for molecular testing? Probably the first question.
Yeah, like, right? Can you do like sub-centimeter cysts, for example?
It's as much as to basically your gastroenterologist. If your gastroenterologist can needle it, which the guidelines actually say 1.5 centimeters is when you start to needle it, but we have a lot of patients with 1.5 centimeter pancreatic cysts. And so there really has to be an indication. So if the patient is in their 60s, if the patient's in their 80s or 90s, is it really necessary to do an EUS FNA on those patients? I think that's a very valid argument. But same thing goes with if the cyst has been stable for 5 to 10 years and they've seen it incidentally on imaging and no one's ever bothered testing it, there's no need to FNA it either. Those are going to be stable cysts. These are typically the cases where you have like a 50-year-old or 60-year-old that has a cyst that was identified incidentally. It's 1.5 centimeters. Gastroenterologist wants to evaluate it to determine, is this patient going to get onto a surveillance protocol? And that's where if they're going to FNA it and they're going to send something for cytopathology or amylase, why not send for molecular testing as well to get enough information? It's a question of what, if you only had 100 microliters though, what would you do with it? And that's the challenge. I would say cytopathology is the first step, and then everything else is molecular, and then CEA, et cetera. Yeah.
Great, thanks.
Well, enjoy the rest of your time at the meeting. If there's any additional questions that if you didn't want to ask on the microphone, you can just come up after. But thanks for coming. Appreciate it.